Okay, recording, and I'm going to share my screen with you all. Come on. Can everyone see that? Codes? Excellent. Okay. Let me just pop in the waiting room. Okay, so we are recording. We're going to get started. Here we go. A lot of this stuff because of simulation last week, and your lectures already with Janie on respiratory and burns. A lot of this is going to sound familiar, okay? But there are a lot of pieces that we haven't touched on yet. Some of you that work in the hospital, this might just seem just very familiar, you're very comfortable with it, and that's great. A refresher never hurts any of us. I know every year that I go back for my BLS and my ACLS, or every 2 years, recertification, I feel like I learned something new. It's constantly changing about the process that we take, the steps that we take. And so hopefully you'll learn something new, even if you feel like you're very, very comfortable with this material because of your work in the hospital or elsewhere. Maybe you're a medic or something like that. So, okay, so with this lecture, we're going to basically go over talking about our objectives, I guess, would be to talk about like the team that's involved with code situations, looking at the primary survey, talking about cardioversion versus defibrillation. We touched on that already, as I mentioned last week. Excuse me. And some of the causes that a patient might go into cardiac arrest. Let me get rid of this mouse. It's just in my way. I'm going to use my little arrow keys here. Okay, there we go. I think that'll work better for me. Okay, so with the team, when you have a code situation, of course, we call code overhead. Somebody pages that out for you, and you get a lot of extra people that come running, and that's great because you can't run a code by yourself. There's just way too much to do, way too much that has to be analyzed and documented. So usually at the start of the shift on most units, someone is designated to be part of the code team for the day. And that doesn't mean that you just help with a code that is on your unit if one should arise, but when they page out a code overhead, then if you're on that code team for the day, then you go running to wherever it is. Gotta get somebody in from the waiting room here. So most units, that's how it works, is that, if they call out a code, same thing happens really with rapid response. People are assigned to rapid response team for the day. Some people are assigned to the code team for the day. And so if they page that overhead and you're the person for the day, then you go running no matter where it is, cafeteria, parking lot, the 3-tower, wherever. So different roles here. The physician obviously is going to direct the code. They are going to be the one asking the questions. How long have they been down? When was the, last whatever medication? And telling us, what to do in that situation. As I mentioned, unit nurses from all over the facility tend to go to the code, and it's going to take more than one nurse. 2, 3, 4 nurses are probably going to show up because we have a lot to do during a code, and you might have 2 or 3 nurses that are working on medication administration. You might have a nurse that is being the timekeeper. You might have somebody like the house supervisor that shows up and they end up being the timekeeper, and that's great. It just depends, but it's not just one nurse, one doctor, and one respiratory therapist, I guess is what I'm trying to say. If anybody's ever experienced a code situation, whether during clinical or at your workplace, you have seen to where the room is very, very full and almost coming out into the hallway. There's a lot of people there. Now, with that, I will say that if you don't need to be there and you're just kind of in the way, if you're there just out of curiosity's sake, that's the wrong reason to be there, so just remove yourself. And I wanted just to touch on, too, again, with multiple nurses and pulling up medications, people that have had surgery, people that have been under anesthesia, sometimes will go into a code situation because they're having a reaction to some of the anesthetic, and they get into a situation that's called malignant hyperthermia. And when a patient gets into a malignant hyperthermia situation, there's a medication that we have to mix up and administer to them, and it's called dantrolene. You don't really need to know that, but you might see it at some point. But I mean, I don't think I have a question on the test about it, but it's just good to know. But anyhow, dantrolene is almost like pancake syrup. It is incredibly hard to pull out of the vial and into a syringe. But before you can even ever do that, you have to reconstitute it. So it's a powder. It looks like orange Kool-Aid crystals in a glass bottle, and you have to, reconstitute it. And then when you mix it up, you're rolling it and rolling it. And when you try to pull that out, I'm serious, it is so thick. It's like pancake syrup. And so it takes, if you ever get into a situation post-operatively, if maybe you work in the recovery room, a lot of times that's where it starts to happen. If someone's going to go into malignant hyperthermia, it really can happen within 72 hours of their operative procedure. But that's typically where it happens. So if you go there to work, you might see this. But it is so thick that you, as one nurse, you can't do it fast enough as the patient needs it. So that's just an example, but again, that's just extra information to tuck in the back of your hat. So you're going to have more than one nurse. You're going to have the timekeeper, and you may even have two timekeepers, because we need to be documenting every single thing that happens, when they went down or when they were found, when another IV was started, when they were intubated, when compression started, how many cycles of compressions were on, what medication was administered at what time, that sort of thing. And then if there is a chaplain in the hospital, they will make their way to that room. Now they might just be standing out in the doorway, and that's fine, just because it's so crazy busy in there. But a lot of times, like if someone's of Catholic faith, the priest will say, can I come in and give this person, last rites? And it's just, traditional things with different religions and that sort of stuff. But respiratory, you guys know this from your lecture with Janie, respiratory can do the intubation, the physician can do the intubation. So respiratory is typically going to go straight to the head. They're going to take over the bag valve mask, and then they're going to get that patient intubated. Okay, so equipment that's needed, you have that here on your slide. Also, much like assigning someone to be on the code team for the day at the beginning of the shift, also we check all of our equipment at the beginning of the shift. So with the crash cart, it's usually locked with a little plastic tag that has an imprinted number on it. And if it's locked and in place, that means that that cart is fully stocked with all the medications and supplies that you need in a code situation. Typically, it's restocked from pharmacy from a medication standpoint. And then, it's kind of a joint effort between pharmacy and someone on the unit that's assigned to overseeing that, to make sure that all the IV catheters got replaced, suction catheters got replaced, syringes got replaced, all that stuff. But pharmacy usually applies that new tag with the number. And so at the beginning of the shift, somebody's responsible for going to that crash cart, making sure that little lock tag is on there. Excuse me. And then there's a clipboard usually on top of the defibrillator where you record the number of the lock. And it basically just says, hey, this has been checked. I know that if we have a code today, that everything I need for that code is in here, and I'm going to be able to implement whatever it is the doctor asks of me to implement, in a timely fashion, because I'm not going to have to go running around to supply rooms and, excuse me, looking for this stuff. It's all there. So it's just a way to know that we've done our checks and balances and we're prepared should we need to get in that cart. Now with the defibrillator or the AED and the suction machine that sit on top of the cart, those are also typically put through a test at least once a 24-hour period, but sometimes once a shift. So it might be done with the day shift and the night shift, since most of our places work 12-hour shifts. So there's basically a way just to test it. You turn it on. You'll learn that during your orientation, and it basically just it does like an internal check to make sure that it's ready to deliver a shock should one be needed. Does anybody on here work in the operating room or over in Levine's? If you do, just unmute yourself.
You mean like Levine Children's Hospital?
Yeah, I'm sorry. I should have clarified, because I guess there's Levine Cancer as well. Yeah, Levine Children's or the operating.
Levine Children's.
I work at Levine's as well, Miss Steven.
Okay, so tell me, what does your crash cart look like? over in the PD hospital? Is it red or blue?
Ours is
Drawers are
white.
blue.
Or is it
Pardon? I think a couple of,
I know on my unit, our drawers are blue.
okay.
Our like cart is white. I've never seen the inside of it though.
I think our
Okay.
drawers are red, to be honest with you.
Okay. Well, so a lot of times, does anybody work in the operating room? Nobody works in the operating room. Okay. So a lot of times, I'm actually kind of surprised to hear that about the carts at Levine's, but maybe that's because it's specifically in the children's hospital, and I guess that could be the difference. But when you're in a department that, I gotta get somebody from the waiting room here. Hold on a second. When you are in a department that services both adults and children, you're going to have two different carts. And so I guess that makes sense that, in Levine, you're saying yours is either all red or all blue or all white or whatever, because that is just a children's hospital. But when you're in a place like the operating room or the recovery room, and that services adults and children, you're going to see two carts. You're going to see the adult cart, which is probably going to be like red, all red. And then you're going to see another cart that is typically white, and the drawer fronts are different colors: pink, blue, aqua, yellow, so on and so forth. That's called a Broslow cart. That is specific to children. Does anybody remember back in peds, did you guys talk about a Broslow tape that you lay out and you lay the baby on top of it, and that's how you determine their weight, is based off their length laying on that tape? It's interesting. You should look it up, and just, if you're not familiar with that, or if it doesn't sound familiar to you, it's Broslow, Braslow, I believe. But anyhow, that cart is a crash cart. It has everything in it like a regular crash cart does, but it is for kiddos. And so the color-coded Broslow tape, it looks like a really fat paper ruler that you lay like on a bed, or beside the patient on a bed. If it's a little baby, you can lay them on top of it. And wherever they measure from the end of that tape to where their head is, whatever color that is, it says that this child falls within this weight range of kilograms. So let's say their head lands in the purple square when you lay them out on top of it and measure them. So then I know that that child is needing the supplies in a code situation from the drawer of the crash cart, the Broslow cart, that's purple. If their measurement of their body lands in like the green or the pink or whatever, then you just go to that drawer. So what happens in the PD Broslow cart for a code situation is, when I would open up, let's say, the pink drawer, it would have all the ET tubes, all the IV catheters, all of the oral airways, suction catheters, and everything that would be most appropriate for that size child. So, because let's face it, as you're growing, you're changing a lot of sizes. Now, when we get to adults, sure, we have a variety of sizes too, of ET tubes and things of that sort. The nasal trumpets, I think Janie showed you those this past week. There are still some sizes, but it's not such a huge range like you would have from birth to, 20 years old. So that's a pretty cool thing. So if you get to the OR, to the recovery room at some point, look for that. It's called a Broslow cart. It's pretty cool. So, okay. I think that was all I wanted to tell you on that slide. Let's move on. Okay, so now we're going to get into our primary survey. This really should be nothing new. We get into airway, breathing, circulation, excuse me, and defibrillation. You've got to survey the scene. You all have gone to CPR class at some point. You come upon the scene and you see somebody laying there, and you're trying to find out, are they okay? Is the scene safe? That kind of stuff. But we always have to be thinking ABC. Even though now in CPR we catch a cab, we do circulation by doing our compressions first, and then we go to airway and breathing. And we'll talk about that more in a little bit. But our primary survey is always thinking airway, breathing, circulation, and D for defibrillation. So when I'm looking at my patient, I'm asking myself, okay, are they apneic? Are they pulseless? Are they unresponsive? And if you're answering yes to those things, then you need to be calling a code, send someone to get the AED, and you need to get on their chest. You need to start CPR immediately. Okay? Get on their chest. Can't stress that enough. But we do think ABC. Are they apneic? Are they pulseless? Are they unresponsive? All right. So what is our goal? Well, cerebral resuscitation. We've got to get blood, oxygen-rich blood, going back to the brain. Okay? So cerebral resuscitation, maintaining our blood pressure, preventing or reducing already elevated ICP, and maintaining a MAP of 60 to 150. Now, of course, we want to maintain ventilation status too, but again, we've got to get the blood pumping. So with this, our MAP of 60 to 150, the MAP really is the best indication of perfusion of oxygen-rich blood to the vital organs. We're thinking, you know, our brain and our heart, obviously, our lungs, our kidneys, but we've got to get that blood moving. So the MAP is going to be your best indication of that perfusion to the vital organs. It's measuring the pressure in your arteries, and so pay attention to that number. If your patient has a low MAP, what might we think is going on with them?
There can be internal bleeding.
Absolutely. Absolutely. What else?
Like hypovolemic shock.
Yeah, they might be into a shock situation.
They could also have had a stroke.
A stroke, fantastic. I'm not sure who said that. I've only got just a tiny few pictures on the side because I'm trying to look at the presentation, so great job. Yeah, all good answers. One more thing I'm thinking about that might be giving us a low MAP.
Sepsis.
Sepsis, fantastic. You guys are smart this morning. Holy smokes, good job. We got all the things that I wanted you to get. So yeah, those all could be reasons for a low MAP. So how are we going to treat this patient? You know, here's the situation. You're the nurse. What are you going to do? You identify this. What are we going to do? Well, they're probably going to need a blood transfusion. They're probably going to need some vasopressors. They might need one or the other. They might end up needing both, blood and a vasopressor. So just kind of think about that. But we need to get those vessels constricted so we can get that heart, we can get that blood pressure up. We can get that MAP back up. And you know, we need to get that heart beating faster, carrying that oxygen-rich blood. Now, we don't want to get it beating too fast because we know that's not good for us either, but we need to get that MAP back up. So vasopressors, constrict those vessels, and maybe a blood transfusion too. So, okay, good. Yeah.
Would you start a blood transfusion during the code situation, or would that be after?
I have seen blood given, you know, not at the initial start. There's other things that we need to be doing first because we need to get the heart pumping. So I haven't seen it at the beginning, but you know, toward the end where we're starting to get, you know, some recovery, I have seen them hang. Mm-hmm. Yeah.
Miss Teben, I saw once during a code, we had a patient who was bleeding out, and the rounding nurse put them Trendelenburg on their head to like keep the blood going to their brain. And, you know, they were just like pushing in a lot of fluids to kind of help keep everything going.
Yeah. Yeah. And you will see that. And again, if we don't get that cerebral resuscitation going, if we don't get good oxygen-rich blood perfusing, you're going to have a patient with an anoxic brain injury, and they're going to live in a nursing home the rest of their life, or a skilled facility, because they are not going to have the neurological function. You might get their heart and stuff back, but if you don't get that oxygen-rich blood going, you're starving their brain of all that oxygen, and so basically you end up with an anoxic blood injury. So, you know, tipping them like that, getting all that blood going to those vital organs, you know, that are up in our chest and our head, pretty important. So, yeah, you might see that for sure. Yep, we've got to get oxygen to the brain. So 3 things that I want to touch on that have been proven by research and data collected over years and all over the world, that give us improved outcomes in a code situation is effective early uninterrupted CPR, which is why now, like I said in your ALS or not, excuse me, BLS class, that we switched from ABC to CAB. Now we start with compressions because we've got to get it circulating. We've got to get the blood circulating. So early uninterrupted CPR, get on their chest. The second thing is early defibrillation. Get somebody to bring that AED to you. You need to see if we can get them back into a good rhythm, okay? And the third thing in a hospital setting is we put our patients now, I don't know, maybe over the last 10 or 12 years into what's called therapeutic hypothermia. So basically we're trying to cool the body down, let it recover. It has proven to help us with better outcomes. So now obviously if you're out on the street and somebody collapses in the grocery store parking lot at Publix or whatever, that's not something you're going to be doing then. You're just going to get on the chest and you're going to start working on them. This is something that would be done much later in the hospital setting. Okay, but those things research have proven to us that they're going to help our patients. Okay, so with airway, intubation, you guys learned a lot about ventilators this past week and about ARDS and respiratory failure and all kinds of stuff and people being intubated and different types of ventilators. Well, with all that, you learned about the ET tubes and the cuffs and things that are on them. So I'm not going to go into a lot of detail with this. You have plenty of things there on your slide, and at this point, it should look just like a refresher from Janie's lectures this past week. But it's really important to inflate the cuff on the ETT. It helps us to decrease the risk of those gastric contents coming back up into the airway. And what do you know? That if you're putting air into somebody through an ETT and the cuff is not inflated, it's the air that you're pushing in is going to move to the area of least resistance, which is right back out around the tube if the cuff is not inflated enough, right? So inflating that for multiple reasons. And you've got that pilot balloon on the outside that can kind of tell you how taut that balloon on the inside is, or that cuff on the inside is. Most times you won't have to stop your compressions in order for someone to intubate. Now, if it's a large person sometimes, and the compressions have to be a lot harder because you've got a lot more body, I guess, mass that you're working with. Sometimes the shaking's a little bit too much and somebody may ask you, hey, just briefly pause. I visualize the cords. I just need to slip the tube in real quick. So they may ask you to briefly pause to intubate them. But sometimes people can do it while you're doing compressions. Again, it just depends on how much the body is being tousled around, I guess, with each compression. But we have to remember that we need to be off of the chest as little as possible, because again, we talked about this last couple of weeks. We can give somebody all the oxygen that we want to give them, but if we are not moving that oxygen that's in the blood, we are not doing them any good, right? So the only way to move the blood is to keep that heart pumping, and that's through our compressions on their chest. So keep that in mind. You want to be off the chest as little as possible. You may or may not have to stop for the intubation. I'd say most people are probably going to say, I visualize the cords, just stop for 1 second and let me get this through, and we'll carry on. Okay, this next picture really should be no surprise to you after your lectures last week. You see the pilot balloon there right in the middle of your screen. This is ETT, and you see the cuff at the upper left-hand corner of the screen there, just showing that it's inflated. Again, you're feeling that pilot balloon, and that's giving you an idea of how inflated the cuff is, but it's not really a measurement. A lot of times we do end up putting in, 7 to 10 mLs, but it doesn't mean that, oh, if I put in 10, that it's absolutely sealed. It might need a little bit more, it might need a little bit less. And we verify that by doing what? We verify if we've got a good seal with that cuff. How?
Listening to the patient.
Listening. Yes, listen. Yes, absolutely. So it's a good check about how tight is that cuff. but it doesn't mean that it's a good seal for your patient. So listen, we can't get away from looking at our patients and listening to our patients. Okay, moving on into breathing. We've got the airway secured now with the ETT. Now we have to breathe for this patient. So how am I doing on time? Okay, we have a few minutes still. Excuse me. So we've got to breathe for them. So, you know, before they were intubated, we were going to use the mask in the bag, and we were going to do that breathing just, you know, with that. But once they got that advanced airway, which is the ETT, now we're going to hook up our bag to the ETT, and we're going to breathe for them that way. So if I just had a mask, if my patient wasn't intubated yet, a mask in the bag, and I'm breathing for my patient, who knows how many breaths or how often do I give those breaths to my patient?
Respiratory will usually say like every 4 seconds. That's what they usually tell us.
6 seconds.
Okay. So if we're actively doing a code and somebody's compressing and I'm the person squeezing the bag, what does our cycle look like, I guess is what I'm trying to get at.
Well, it's 30 and 2.
30 and 2, right, 30 and 2. So we're doing 30 compressions for every 2 breaths. But now respiratory has intubated my patient. So we have an advanced airway. So now how often, since I'm not going to be stopping compressions to give breaths like I would do when CPR initially starts, how often should I be squeezing the bag to give them a breath?
6 seconds. Every 6 seconds.
Yeah, absolutely. 1 breath every 6 seconds, okay? And it's really important too. You'll see some people and they have great intentions, but they're like really squeezing that bag. You don't have to like collapse that whole bag. That's not really what we're aiming for. You need to squeeze it, but you're not trying to get all that whole big bag full of air into that patient in one breath. So,
Miss Teben?
Yes.
Quick question for you regarding the 1 breath every 6 seconds. I know that's what like BLS says to do, but that's a respiratory rate of only 10. So isn't that too low?
So yes and no. We're giving them enough oxygen through that bag that as we're compressing, and because we're not stopping and starting, whereas with compressions, we stop and then we give 2 breaths, but we're giving them all that air, but then we have to start the circulation back up. And if you're giving them those 10 breaths, about 1 every 6 seconds, yes, it is a little bit slower. However, it's constantly moving because the circulation through our compressions is not stopping. So it's not like it's sitting here and it's waiting for the compressions to come and grab it and then start circulating it. It's as it goes in, it's being utilized, and it's going in and it's being utilized. So yeah, some people will say you can do it every 5 to 6 seconds. I would say that's fine. You're not going to probably want to do it any more often than that because we don't want to cause we don't want to cause more damage than's already there. You can actually end up putting too much air into a patient as well. So keep all that in mind. I gotta get somebody in here from the waiting room.
Miss Teben.
Yes.
So when the patient is on the mechanical ventilator, we're doing chest compressions nonstop, and the mechanical ventilator is administering these breaths once every 6 seconds.
So we're just talking about, we're not talking about them being on a ventilator at this point.
Okay.
Yeah, a ventilator will come later after we bring them back. Right now we're talking about giving them air initially in a code situation through the mask and the bag, squeezing 2 breaths every 30 compressions where the compressions stop and then you're giving the 2 breaths. Once the doctor or respiratory has put the advanced airway, the ETT, down their throat through the cords, then we're going to hook the bag, we're going to take the mask off the bag, we're going to hook the bag to the ETT. At that point, you don't stop compressions to give the 2 breaths. Respiratory or whoever is manning the airway is going to just breathe every, I guess you could say 5 to 6 seconds as the compressions continue. The ventilator is going to come later after we get their cardiac function back, and we have to move them to like an ICU or something like that. Okay. But so anyhow, with breathing, it's important that you look at your patient's chest. What are we looking for?
Chest
Rise
rise.
and fall.
Chest rise and fall, absolutely. Because what do we know sometimes if we're just breathing, somebody with a bag and a mask, or even with the ETT, if we didn't listen with our ears and verify placement after we dropped that tube in, where might our air be going?
To the stomach.
In the stomach, right. And before you get somebody secured with a cuffed advanced airway, a cuffed ETT, and you're just using the bag and the mask, and you're giving them breaths, if you don't have proper positioning of that patient with their pillow being removed from underneath their head and using that head tilt chin lift, you're probably forcing the air from your squeezing of the bag into their stomach and not into their lungs. So you've got to remember to get your patient in the correct position if you want your ventilation efforts to help. Otherwise, it might just be filling their belly full of air, and without an advanced airway with a sealed cuff, what might happen to my patient? If I'm putting all
on the gastric contents that come back up.
Yeah, you might have a whole lot of vomit coming your way. Yep, a whole lot of vomit, because if we don't have them in the correct position, that airway clearly open through head tilt, chin lift, the pillows out from underneath them, we've got them flat, and I'm watching to make sure that my air is going into my chest. That vomit from the air going into the stomach, all that's going to come back as vomit right up and out the mouth. And what happens in that situation sometimes, if a patient has a vomit in their airway? Aspiration. And then we're into another huge problem, aspirate pneumonia. And then you would talk about a bunch of stuff growing in your lungs. Not a good situation. So it's important to make sure that you've got that patient positioned properly. And then as you ventilate, you're watching for that chest rise. Now, you're going to watch for chest rise no matter if you're using the bag and the mask or whether you're using the bag and an advanced airway, an ETT. Okay? Really, really important. Okay, so when somebody is intubated, you're going to be watching your monitor. You're going to be seeing the pleth on the screen there, and watching how their respiratory efforts, what the respiratory efforts are looking like. There might be this little adaptive piece that you see here in the upper left of your screen. That's a CO2 detector. A lot of times you'll see that with anesthesia in the operating room, and they're just basically monitoring, the patient's CO2. It does change color. It's got different measurements on the sides of that block, and it hooks into the line of the ETT as they're being ventilated. Somebody on a ventilator as well, you might see that on there, but it just kind of lets us know what their CO2 is doing. It's an easy way just to kind of check that. There also is a device, I don't have a picture of it here on your screen, but there is also a device that now hooks in line to the nasal cannulas. And a lot of times in recovery room, you'll see those in line. It hooks up to the monitor, and it can tell you really how well is the patient, not only you're going to see obviously their SpO2, but it's also going to let you know kind of their CO2, like what are they breathing off? So just something to look at. That's all I'm going to say about that. So circulation, again, I said this is really important. Yes, we have to make sure we secure that airway. We need to make sure we breathe for that patient, but we have to circulate whatever we're giving to them. So without circulation, again, is the oxygen going to reach anywhere that it needs to go? The brain, the heart, the lung, the kidneys, anything? No, it's not going to. It's not going to at all. So it's important that we get on their chest when we're thinking about you know, in a situation where you find somebody that is down, you get on their chest and you start compression so we can start circulating right away. So we already talked about this in your CPR. Now we do 30 compressions to 2 breaths. For an adult, how deep should each of my compressions be?
2 inches.
2 inches.
2 inches, absolutely.
East.
2 inches of depth with each compression on the adult. Now, just as important as the compressions are, what is equally important with the compressions? Not only the depth, but what?
The rate.
Allowing the rate.
Allowing for recoil. Absolutely. You guys are smart. Good job. Because what happens during my recoil? What happens when I release my pressure of my compression? What's going on in? I'm sorry?
Chambers to
The
fill.
cardiac.
Yeah, so my ventricles are going to have time to fill back up, right? If I don't let that off, then they're not going to get enough blood to really give us a good gush and send out enough oxygen-rich blood, I guess you'll say, to the rest of the body. So while compressing 2 inches deep for an adult, 30 times taking a rest for 2 breaths, it's also important to make sure you allow that recoil. Now that doesn't mean, and you guys should all know this from your CPR, that doesn't mean that I remove my hands completely from the chest. It just means that I take the pressure off. So you're using that motion with your elbows to compress them. And so your elbows should come back into a flexed position when you're allowing for that recoil. And then you're, you know, extending them into the chest 2 inches, you know, to compress, to pump. So you're not physically removing your hands from the body and then having to find your landmarks again to start the compressions is what I'm saying. Okay. Where is my hand position for compressions?
Kind of dead center of the sternum, maybe a little bit lower.
Okay. Yeah, right there over the sternum, about nipple line. It's real important that you find that position that you need to be in, and then you leave the butt of the palm of your hands, you know, in that position, although not putting pressure on during recoil. Now, I know many of you work in the hospital as techs, and some of you are medics and other things. So you may have already seen this. You may have even seen it over in the simulation center at the school. But we have now on our defibrillators a puck. It looks like a hockey puck. Has anybody seen that? And we use it during CPR? Okay.
Yeah.
So great. So basically you take this puck that's hooked with a wire to the defibrillator, for those of you that haven't seen it, and you lay it over the position on the chest where you should be doing your compressions. And then your hands go on top of that puck. And so as you compress, that puck is between the patient's body, the patient's skin, and your hand. But what it does is it transmits the information about the quality, the rate, the depth of your compressions to the monitor. So then your teammates can say, you need to push harder, you need to push faster, you're pushing too fast. You're watching this tracing on the monitor, and it helps you to give more effective compressions, more effective CPR. So you're probably going to see that at some point in time if you have not already. So that's really, really helpful. And you just, you know, everybody's supposed to give that out loud verbal feedback. If somebody's going too fast, too slow, compressions are hard work. You get exhausted very, very quickly. And again, we have to do them, and we should jump on their chest and do them first, because without the compressions, we're not circulating any oxygen to the brain, and we're going to end up with an anoxic brain injury. Now, for those of you that also work in Atrium, and I don't know if Novant's doing this or not, Wake Forest that's joining our partnership, they also, they've done quite a bit of research with this as well, but it is called Team Steps CPR. And basically that is just like continuous compressions. They're not stopping to give the 2 breaths. And you'll see people go 2 minutes straight giving compressions without stopping just to keep that circulation going. So why 2 minutes? Who came up with that magic number? Why do we only go 2 minutes? Who's done team CPR at Atrium, and who knows why do we go 2 minutes? Jonathan, you know? What's going on?
I mean, I would think what we usually do if you're doing it like that, you do 2 minutes and then you do a pulse check to see if you have anything. But as far as I know, that's about how long it takes you to get tired with compressions, and so they have somebody switch on.
Yep, that's exactly right. So the 2 minute time frame basically came up with, a lot of research and talking to a lot of people that have been involved in code situations and doing compressions, and they said, they really can't go beyond 2 minutes. That seemed to be the time that everybody said, I'm exhausted, I can't do anymore. And if you've ever been in a situation where you have given compressions, it is extremely hard work. I know some of you are quite the fitness buffs and, do lots of running and weightlifting and yoga and all kinds of stuff, but it is a whole different kind of workout. It would be like if you normally do, let's say you ride your bike, 10 miles a day, but then you decide, oh, well, I'm pretty physically fit and I'm just going to go run a marathon. It's a whole different kind of use of your muscles. It's a whole different kind of workout, right? So CPR is kind of like that. No matter how fit and how trim and how young and healthy you are, it is exhausting. It is absolutely exhausting. So research has showed that 2 minutes is about the length of time people can go before they become so exhausted that the compressions they're giving are not effective compressions. They're not the right rate. They're not the right depth. They're maybe not allowing off enough recoil. So we need to switch out people because, again, we need to make sure all those things are in place, all those measurements are in place to get good circulation of the patient. So about 2 minutes, okay? Again, with circulation, it's important, remember, flatten the head of the bed, remove the pillow. You obviously are going to have a difficult time if your patient's sitting way up in the bed like this. They're sitting, semi-Fowlers or Fowler or, whatever they're sitting. You're not going to be able to compress their chest, right? So flatten the head of the bed, get that pillow out. That's going to help with our ventilation efforts as well. Get that patient on the backboard. Now, some of our newer beds actually have a mechanism, and when you pull the lever or step on the pedal on the bed that says CPR, it will automatically inflate and harden for you, which is fantastic. But if you don't have one of those beds that your patient is in, most of the headboards and footboards come off and act as your backboard. Now, as soon as somebody rolls up in your room with a crash cart, there's usually a backboard on those as well. So, but that doesn't mean that we're going to stop CPR to take out the headboard that we were initially using to switch out to a different backboard. That wastes time. That's time off the chest, and we don't want time off the chest. But just know that there's multiple things that can be used. And get familiar when you guys go to orientation, when you go to preceptorship, and then you get out into practice, get familiar with the beds that are on your unit and identify where the CPR lever or pedal is on the bed so that you know what you need to activate in a code situation so that you can give good compressions. If you don't have something firm behind them, you're going to feel like you're just, pushing into a bowl of Jello because it's just going to be squishy. Okay. Now, also, in order to give good circulation, good compressions, not only the rate and the depth and the recoil, but if you are vertically challenged like I am, we are not short. That is not a word in my vocabulary. We are vertically challenged. Happens with IV pulse too. Make sure that you find a step stool and get it at the bedside so that you can be up and over top that patient in a proper height and position that you are going to continue to give good quality compressions. If you are struggling to reach that patient, if somebody raises the bed up to my chest level because they need it high enough so they can intubate the patient's airway, well, then my arms are up here and I'm not able to compress like I need to because the patient overall in the bed is higher than what's really comfortable for me. So I'm not going to have them lower it so that they struggle with intubating the patient because we know we need to get them intubated and get oxygen to them as well. But I'm going to make sure that I have a step stool so that I can be up and over top of the patient. So get a step stool, lower the rail between you and the patient. So again, it's not another obstacle in your way, interfering with good quality compressions. Okay? All right. We're going to do this slide and then we're going to take a break. So defibrillation. We said airway, breathing, circulation, now defibrillation. We've talked and talked and talked about this. Why do we defibrillate? Who do we defibrillate?
Someone's dead.
Someone's dead. D for defibrillation. D for dead. Yeah, it's not rocket science. We're just doing it, right? We're going to talk about cardioversion in a little bit. But through defibrillation, we're trying to get the SA node that we know is our heart's pacemaker to regain control of what's happening, okay? So with our defibrillation, we've got to place the pads on our patient that arrive with the AED or the defibrillator. Where do my pads go and what are they called from an anatomical landmark perspective? There's two different names for my pads. Where do they go?
For the ones that I've seen, usually have one that goes on the right side. It goes up like towards the shoulder.
Okay, right upper chest.
And then one that goes underneath like the left side of your chest, below the nipple on the side.
Yeah.
Kind of.
Okay, and so who can help here? That's right, Jonathan. What is this pad that goes on my right upper chest called?
A sternal pad?
Sternal pad, excellent. I'm not sure who said that because I can't see all of you while I have the screen share going on. Excellent, okay. So then this other pad that goes, Jonathan was saying, like goes like over here on the side, okay? And if you have a large breasted woman, of course you need to, move the breast tissue and get it, really onto the chest wall. What is that pad on my left lower side called?
The apex pad.
The apex pad. Perfect. Perfect. That's the positioning. Now, for kiddos, you might have a pad that goes on their front and a pad that goes on their back, right? Okay. If I have in my crash cart that comes, if it didn't get stocked properly, let's hope that doesn't happen, but if it didn't get stocked properly, and I have an adult, a 36-year-old male that I'm doing CPR on, and the pads arrive, and I open it up, and all I have are pediatric pads. Can I use those?
I mean, I think so. I mean, it's better than nothing, right?
Right.
When it's still, I don't know. Maybe it's just only vice versa. Like you can use adult ones on peds, but I don't know.
Okay. Carissa, you were saying no. Is that correct?
Yeah, she kind of answered it. You can only use adult ones on peds, but not peds on adults.
That's correct. Right. If you use a pediatric pad on an adult, you're not going to have enough surface area covered and enough electricity transmitted through those small pads to be effective. So you can use adult pads on a kiddo by putting one on their chest and one on their back, but using pediatric pads on an adult, you cannot do that. It's not going to work. Okay? Now, what is something else that's so important with putting those pads on to make sure that I have really good conduction, that I have a good adherence?
Maybe like shave some of their chest hair if they have some.
Yeah, chest hair if they have some.
Wiping off like moisture, excess moisture and stuff like that.
Absolutely. What are some other things that we might need to take into consideration when we're putting those pads on?
Pacemaker.
I'm sorry?
They have a pacemaker.
If they have a pacemaker, or what else that goes underneath our skin?
A port.
A port, right, for long-term therapies, chemo or something of that sort. So be careful about putting those pads. You don't want to put them on top of any of those things. Also, medication pads. So nitroglycerin pad, a lidocaine patch, a nicotine patch, any of those things. Nicotine patches typically, we tend to put them on the arm. They might go on the chest, but typically the nicotine we rotate between the arms. But lidocaine, nitroglycerin, those could easily be on the chest. Now, if it's lidocaine for knee pain, obviously it's not going to be on the chest, it's going to be on the knee. But yeah, make sure that you are removing any medicated patches and wiping that area clean. Brad said removing any excess moisture So if they have, if they're profusely sweating, you might wipe that area really well before you slap that pad on. Hair removal. So hopefully, there's a little razor in the kit that comes with the pads, and you can quickly remove some hair. Now, you don't have to get the most beautiful, perfect shape, but you need to get the bulk of that hair off so that we can have good conduction, good adherence of that pad, and that electrical current that we're sending to them can do what it needs to do. If you're in a situation out in the community, you know, we have AEDs and things in churches and supermarkets everywhere now, the airport, and there's not a razor, and you've got a hairy chested man, and there's not a razor in the kit, but you've got pediatric pads and adult pads. You could put the pediatric pads on just for simply giving them a quick wax job and quickly remove them and pulling a lot of that hair off, and then put the adult pads on to actually deliver the shock. But otherwise, you know, using PD pads on an adult is not going to be effective. Not going to be effective at all. So, okay, we're going to stop there. We're going to take our 10-minute break. We're going to come back at 10:02 and we will resume with this. And I think we'll probably be done even a few minutes early. Okay? There's some people popping back up. Hopefully you guys refreshed your coffee or whatever it is your flavor is this morning. We'll get going here. Okay, it's 10:02. We're going to pick right back up. Okay. So continuing on with defibrillation, if I can get my mouse to work. There we go. So we have different types of defibrillation. We have external, and then we have internal, and of course we have implanted, like an implanted cardiac defibrillator in someone's chest. Sometimes people have a pacemaker defibrillator combination. So with external, of course, that's most often what's used in a code situation, delivering the energy through pads or paddles. Now, on TV, you typically always see the very dramatic paddles and, you know, them shocking someone's chest. Most of our AED defibrillators now come with the pads, so we get that real good conduction. We get that good adherence with the adhesive, and we deliver that way. With internal, that's basically where the chest gets cracked open. You'll see this happen in the emergency department. You'll see it happen in the operating room. And they use like these large spoons or tongs, and they actually, now that, if anybody watches The Resident, I would say The Resident, out of all the medical shows that I've seen over my life, that one seems to be the most realistic. And you'll see sometimes Dr. Okafor and some of the others, they will have these large spoons or tongs, and after they get done doing some massive heart surgery, they put one, you know, at the bottom of the heart and one on the other part of the heart, and then they send the current, and it delivers through those tongs or those spoons, and then you wait a few seconds, and then miraculously the heart starts beating again. But so that's actually probably the most real that I have seen. But you've got to crack the chest, obviously, to do internal. Okay. As I said, the ICD is an implanted cardiac defibrillator. Somebody may have that in combination with a pacemaker, or it might be a standalone. But when we talk about external defibrillation, which is what you're going to most often see, unless you go into like the OR, maybe in the ED, you're going to know that there's two different types. Now, I think the hospital has converted all over to the biphasic Philips monitors, I believe. Maybe there's still a few older ones out there that haven't been swapped out. But biphasic and monophasic, basically, it's just a difference in how the electrical current is delivered. So, excuse me, in biphasic, the shock goes at a lower electrical current, and it goes from one electrode to the other, you know, because we have two pads. So the delivery of the shock goes from one electrode to the other and then back to the original one. And that's how biphasic works. It is more successful from all the research that we have in correcting somebody, getting them out of asystole or whatever dysrhythmia, you know, that got them into the situation. Now, yeah.
I'm sorry. Do you mind repeating the biphasic?
Yeah, so biphasic, you can use a lower amount of electricity, and the current is delivered. It starts in one electrode. It goes from that electrode to the second electrode, and then it returns back to the originating electrode. And so you're able, because it makes that full loop essentially, you're able to deliver a lower amount of electricity using that. It has been proven in research to be most successful. And that's what the Philips monitors at Atrium have. And they'll start like at 150 and they'll move up to like 200 joules. When you have a monophasic, it basically says, I'm going to start electricity in one electrode and I'm going to move to the other, and that's it. It doesn't make that full loop and come back around. But because it doesn't make the full loop, you have to use a higher amount of electricity, like 360 joules. Okay? And really that's the difference between the two. Okay? All right, so now let's get into medication delivery. You will need to know these drugs. You do need to know these drugs. And you need to know how they're delivered, what's appropriate route for them, and that kind of stuff. So that's about as clear as I can be in telling you this, okay? So there's different ways we can deliver medication. We did touch on this slightly last week with the IO in the burn scenario and simulation. We're going to get into that here in a little bit. But the first that you see here on the slide is the endotracheal tube. Now, naloxone, you guys know that as Narcan. Atropine, what do we know that atropine does?
Speeds up the heart rate.
Yeah, absolutely. Absolutely. Some of these other meds on this slide are going to look familiar to it as well. So if I give the meds down the endotracheal tube, I have to give it in a concentration that's 2 to 2.5 times of what I would normally give it in an IV dose. And then you follow it with at least 10 mLs of normal saline, and then you vigorously ventilate somebody because you've got to disperse that fluid. It seems like a bizarre concept because you think, well, normally we're trying to dry up what's in the lungs, right? We normally don't want fluid in our lungs. It's not really therapeutic. But in this situation, this can make all the difference. So putting the meds through the endotracheal tube and then ventilating and dispersing that and covering all that surface area, it really has proven to be effective. Now, I'm going to skip the IO for just a second and go down to the intravenous. When you get to the intravenous, most meds in a code situation, again, we kind of touched on this last week, are given in a pushed method versus an IV drip, right? Because we need to get it in fast. We need something to happen. So if you're giving it intravenous, it's going to be whatever the med is, it's going to be pushed in pretty swiftly. And then that doesn't mean that after we get this patient resuscitated, that you're not going to have to follow it up with an IV drip of that same medication. It's not always a one and done kind of thing. So just know that you might have to follow it up later on with a drip of whatever the medication is. But when you do the IV push, again, we want to make sure we really are getting it into the patient, getting it into that circulation. So you're going to follow those with a 20 ml flush, okay, of IV fluids, normal saline, something like that. Again, we know lactated ringers doesn't play well in the sandbox with many other meds. So you're going to be using normal saline in this situation. So now the IO, I have here on your slide the tibial tuberosity. Who remembers last week what I said is the preferred site for an adult?
Humerus.
Yeah, the humeral head, right? That is our preferred site for an adult. But you could do it down at the tibial tuberosity as well. In a code situation, this whole part of the patient's kind of busy, right? Somebody's trying to breathe for them. Somebody's trying to compress their chest. So you may or may not be able to get to their humeral head. So throw that IO in the tibial tuberosity. We just need to get them some meds and some fluids. We need to get some stuff in the circulation. So as they're compressing the chest, it's carrying whatever oxygen we can get to them. So put it where you can get it. You're not going to do that unless you're specialty trained, but physicians, medics, nurse practitioners, PAs can all do it. If you go to work in the ED, you might get special certification training to do that, but it really can be a huge asset in a code situation. And especially, like I said, if this is busy, throw it in the leg, you're out of the way, you can get it all done while they're compressing, and you don't have to ask them to stop or anything like that. Now, it is preferred over ET administration. So if you had a choice, okay, am I going to put the medicine down the ET or am I going to put it in the IO? The IO would be where your preference should go. Again, depending on the patient's rhythm, you might have to follow up IV push medications with an IV drip. Maybe it's like a lidocaine or an amiodarone drip, something like that, a patient that was like in pulseless VTAC, some of those kinds of things, okay? Now, what I want you to really think about when you're studying and looking at your Lewis is knowing your different IV sites and, thinking about, okay, if I'm putting it in as a regular peripheral IV, I'm not going to fool around with a little 20, 21, 22. I need something large bore, so I'm probably going with an 18. I also want you to think about central venous catheter, central lines. What would be the most appropriate? What's going to get the medicine to my patient the quickest? So with that, I want to know, does anybody know if I had to start a line maybe not me, but a doctor, somebody in a code situation, where would be the best place to start something, no matter if it's peripheral or central line, what have you? What is going to be my best option in order to get medication to my patient the quickest?
Left subclavian vein.
Right subclavian. Why
Or right
is that?
subclavian, sorry.
Yeah, right.
Because it'll get to the superior vena cava fastest and
Yep,
go
it's
into
a
the lung.
direct path to the superior vena cava. So that's going to be the best place. Now, I can't put that in, but that's going to be our best place if we had to get something started. Think about all those things, though. And you need to understand the difference. Something that you should probably look up and read up on is the difference between an internal jugular and an external jugular. Now, the word jugular makes people think right away, oh my gosh, this is like a central line, this is, central venous catheter, whatever. But an external jugular really is a peripheral catheter. It is different from an internal jugular. So I would just recommend being comfortable with understanding that and just knowing the difference. Okay? All right, so you guys saw ETTs last week. This is an example. You may or may not see this. It has always been that they would slide, you see in the middle of the screen, the black tip here. This is a suction catheter, like you guys, trained with for trachs and whatever, suctioning. And here's the top of the ETT that would go to the ventilator or to the bag during a code situation. Here's the pilot balloon. Here's the end of the ETT. This one doesn't have a cuff. Well, it has to have a cuff on. It's not inflated. Okay. My old eyes are having trouble seeing it. But anyhow, the cuff's going to be right around here somewhere. And then here's where the end of the tracheal tube, endotracheal tube is, and this is the rest of the suction catheter. So it used to be that we would always put the medication through this suction catheter, and the suction catheter then down through the ETT. I'm hearing now that they're not always using this. So you may see them just squirt straight through the ETT, but it has always been that we had done it this way before. So I just wanted to show you kind of what that looks like when you disconnect and you slide the catheter through there, and then you could hook your syringe right up to this and put the medicine through it. So just wanted to show you that. Okay, here is the IO that I was talking about. There's different sizes, as I mentioned last week, in simulation for PDs and for adults. You see the little pink one there says 3 to 39 kilos. Well, I don't think any of us weigh 39 kilos. And then you see as they move up to the blue and to the yellow, in different sizes. This is called the Easy IO drill, IO for interosseous. And I'm going to attempt to click onto YouTube and show you this quick little video, but you can watch it. There's videos of live people, paramedics and stuff training on how to put these in out on YouTube, and they have them hooked up to cardiac monitors when they're doing it, and you will see a change in their cardiac rhythm. I mean, imagine how that feels when we're inflicted with pain, and you see some of these big macho grown men kind of get queasy and not feel so great. But I'm going to attempt to get this to work for us here. I don't know if it'll share through Zoom, so my only concern. Come on. Can you guys see that? It didn't pop open? Oh, new share. Here we go.
I'm Dr. Jess.
Can you see it now?
This video is going to show you placement of the
Okay.
EZIO in a real patient, in a real code, in a real hospital. But first, before you get too drill happy, let's go over what's in the kit so you know what to expect. It comes with a drill. Without it, it wouldn't be so easy, would it? It comes with 3 needles. We've only got 2 today because we're on a budget. There's pink for pediatric because all kids like pink. Blue, which is not shown, fits in most adult sites. And then yellow, which works well for the adult humerus and areas of adipose. So you can remember yellow, adipose. You're welcome. Enjoy your dinner. It attaches magnetically to the drill. And then once it's drilled into place, you're going to remove that stylet. Safety first. And then this proprietary dressing fits nicely over the top right there. And you can then connect your tubing. And you're all ready to go. For the proximal tibia, you want to feel 2 finger breadths below the tibial tuberosity, and you're going to go on that anteromedial surface. So you're going to prep the skin, of course, first. Now with your drill, here they're using the yellow one. The blue would also work. Yellow might be a little long, so you just don't want to hub it. You're going to advance it through the skin and then drill until you feel give. That's how you know you're in the medullary cavity. Don't push it beyond that because you don't want to go through the medullary cavity. Now you remove the stylet and you can place that fancy, beautiful dressing. And now you can hook up your tubing. So they're going to draw off some labs here, which is great for things like H&H and type and screen, but some of your elements in your chemistry panel are going to be very different from your serum levels, so you want to be careful. And remember, you can give any medication through an IO line. For infants and kids less than 6 years old, the proximal tibia is actually the preferred site. Here's some other options for placement. You can go in the distal tibia as well, and basically it's like the medial ankle, where the medial malleolus meets the shaft of the tibia. Another option is the distal femur, and for that you would go 2 finger breadths above those wide condyles of the knee, and that's right smack in the middle. And finally, there's the humeral head, and you're going to go in the greater tuberosity of the humerus. Now, if you're going to do this in an awake patient, then I recommend using some anesthesia, and you can use my mnemonic 2 of 2 for 2 times 2. That's 2 cc's of 2% lidocaine over 2 minutes, then do a flush and wait, and then repeat it, so times 2. 2 of 2 for 2 times 2. And that gives your patient 80 milligrams of lidocaine. Some people use a little more, a little less, but that's a safe amount. I also recommend anesthetizing the skin and periosteum before you start.
Wow. Let me see if I can stop that. Okay. Whose stomach flip-flopped when that happened? I saw some of your faces. It was great.
My name is Andrea Herbert, MD, and I'm here to talk about airway.
I thought she was done. Where did she go?
Welcome to
Hold on.
intubation. So today we're going to go through my way of doing
Probably autoplay the next video.
well,
Oh, but I don't even see it.
We're not going to do nasal. We're going to talk about the step-by-step.
Hold on
checking
a second,
equipment,
please. I'm so sorry.
checking
Oh, there she is.
that
Okay, get off of there,
everything we
lady.
have is prepared.
We don't want you anymore. Okay, thanks for your help. We're going to continue on with class. Okay, so let me get back to sharing the other screen that we were doing. And we are here. Okay, so whose stomach kind of flip-flopped? Anybody seen that before? No? Nobody's seen it before? Okay.
I was gonna say it's usually in the proximal, but yeah.
It's quite something. I remember the first time I saw it, I thought, holy smokes, and that guy was awake. But if you're bored, which I know that's not probably something you're finding these days of 202 being bored, you've always got something to do between school and life. But there are plenty more videos out there that give a lot more information about it. You can see it being done on a live person and that sort of thing. So anyhow, my point with this slide is just that, remember, even though they may be unconscious and not responding to us, you know, Janie talked about this past week with ventilators, you know, they might not have their motor function, but they're still going to have sensory. And so you got to think about pain too. I mean, that can't feel great to have that done. I'm sure of it. So I don't want to volunteer for sure for a YouTube video at all, ever. Okay, we're going to move on into cardioversion now. And so with cardioversion, we've talked about this a little bit in simulation. I'm not going to read the slide to you, but basically we know that there's ectopic foci, maybe from a scar, from a previous surgery or something in the heart that may have caused you know, this patient to get into a dysrhythmia. We need to allow the SA node to take back over control. And peds, you guys heard about kids with ventral septal defects. They've got to repair that hole in their heart. A lot of people just say, oh, I had a hole in my heart. Yeah, well, so when we repair things by making something better, we also leave scar tissue behind. And that scar tissue can be the ectopic foci. So, you know, that could just detract everything from moving through the heart the way that it's supposed to. With cardioversion, it uses less energy. During cardioversion, you need to make sure that the airway is being maintained. Now, that doesn't mean that while they're actually having the shock delivered to them that you keep your hands on them. That's not what that means. We're going to go through that in a second. But scheduled synchronized cardioversion happens probably more often than any of us realize, but people that keep going into some sort of abnormal, I can't talk, abnormal dysrhythmia, and the doctors try different medications and things like that, they might get scheduled to come into the hospital, have the synchronized cardioversion done, and then, be monitored for several hours and head back home that same day. Okay, so cardioversion and defibrillation safety. Again, we need to make sure that we maintain their airway, but we need to make sure that we're staying safe. So all personnel have to be cleared before a shock is delivered. That means that you drop, you drop whatever you're doing, you stand back away from the bed, you're not leaning on the rails of the bed, you're not touching the patient. You say, I'm clear, you're clear, oxygen clear. And the reason is we know oxygen is it's combustible. It's combustible. And there have been patients that have had explosion because oxygen was not removed. So that means the person that's ventilating the patient up at the head, when we're getting ready to do cardioversion or defibrillation, they actually remove the whole thing. You're not going to leave the oxygens to hang out there by the patient's head and you step away. No, you're going to take the oxygen source away with you. Now, there's still going to be oxygen in the room, okay, but it's not going to be on the patient. It's not going to be where the electrical current is going to be delivered. And hopefully then we don't have some sort of a combustion, okay? So, again, you're going to, as soon as if it's an emergent situation with a defibrillator, you're going to get those pads applied as soon as you receive them. And then you're going to, depress the button on the machine that's going to say to analyze. And while it is analyzing, you need to step away too, because we don't want to be moving the patient or compressing the patient while it's trying to analyze, because then it's not really going to identify clearly what's going on. And it may say no shock advised because it thinks that there's a heartbeat, but really, in essence, it's you compressing their chest. So while it's analyzing, you step away. And of course, while it's delivering the shock, you step away. So I'm clear, you're clear, oxygen clear, okay? All right. So with ventricular fibrillation, we know that's a lethal rhythm. We also talked about pulseless VTach, okay? So while I kind of have these here in somewhat of an order of how they're going to go, really in a code situation, things are happening simultaneously. So it's not that we're going to do CPR and then we're going to defibrillate, and then we're going to do CPR and defibrillate, so on and so forth. And then, oh, well, when I want to give the epi 1 milligram every 3 to 5 minutes, I'm not stopping CPR. See what I'm saying? It can happen simultaneously, but this is kind of the order of how things start out. The big thing is we get on their chest, we start CPR with compressions right away. Somebody's getting the defibrillator for us. As soon as it gets there, I'm still doing my compressions while somebody else is slapping those pads on that patient, okay? Somebody may be able to get IV access as long as the patient's not, like jiggling too much. They might be able to get that IV access while you're doing the compressions. That is our hope, because any extra time off of the chest is going to diminish our efforts and decrease our positive outcomes. So a lot of this stuff is happening simultaneously. And then we're going to get into treating the underlying causes. Now, other meds that you might be thinking about in a situation like this with VFib or pulseless VTach are the anti-arrhythmic meds. We talked about some of those in simulation last week. So you're thinking about, what are my sodium channel blockers? What are my beta blockers? What are my potassium channel blockers? What are my calcium channel blockers? And knowing, how do those drugs work, okay? And what might be the best. Now, the doctor in the code situation, they're obviously calling the shots, but as a nurse, you've been trained and you should know how those medicines work. Okay, so you guys have seen this. You should all know what this is at this point. It says it right there for you. It's VTach. What did I tell you if you saw this on the monitor? You better hustle to that patient's bedside and you better see, are they pulseless or are they sitting up in the bed talking on the phone? Because it can look the same way whether they're pulseless or not, okay? But we know that somebody can't sustain this very long before they become pulseless or they go into ventricular fibrillation. But it can look the same way on the monitor, okay? Always check your patient. As the nurse, what do? I check my patient. I see that on the monitor, I'm checking my patient. Okay, now getting into the causes, we're going to talk about the H's and T's. I don't think you guys have touched on this yet. Did Jamie touch on any of this in respiratory? I don't think you guys have probably gotten into it yet. You're going to hear it again this semester. But when somebody's in a code situation, you're going to hear doctors say eventually we're trying all this epi and we're giving good compressions and we're ventilating the patient, but nothing's coming around. We're trying to like, okay, what could be going on with this patient? You'll hear the doctor say, okay, somebody, come on, what do you have? Somebody help me here. And, people start talking about what's going on in this patient's history, what has recently happened, what do their labs look like, what really could be going on. So we refer to these lovingly as our H's and our T's. So H is there. If they're hypovolemic, hypoxic, hydrogen ions, hypo and hyperkalemia, hypothermia. You can see all those things there. A lot to really think about. You got to think in tamponade, what's happening? What's going on in tamponade?
Blood's in the pericardium of the heart.
Yeah, so what is that doing, Jonathan?
I was just going to say it keeps it from beating. So it's compressing the heart.
Absolutely. So the heart can't pump. It can't contract like it's supposed to because it's pushing against all the resistance of that fluid that's in the pericardial sac. That's absolutely right. Now, what about this tension pneumo? What's going on with the tension pneumo?
So with, we don't see them that often, but like you have like a pneumothorax and then you either start compressing it or you do something else and you create a tension pneumo. So it deviates the trachea and then it causes a bunch,
and I'm
compresses the heart as well.
Excellent. Where are you working, Jonathan?
The emergency department in Pineville.
Oh, okay. Yep, that explains why you're familiar with some of this. So yeah, an tension pneumo, air is filling that pleural space, right? And so it could be from a laceration, from like a broken rib has punctured, or any of those things. But what Jonathan said is that the mediastinum becomes displaced to the opposite side, and so then you end up getting this decreased venous return. And so they're going to need a needle thoracostomy. So, and Dr. Bonetti's going to get into more of that kind of stuff too when she gets into her cardiac. I think you have 12 hours of that lecture toward the end of the semester. But yeah, so patients are really sick. These are really serious things. They're obviously dead. We're working on them, but we're trying to figure out why, what happened. So this is what Jonathan was explaining to you all. In the top picture there on the right, the pericardial sac that surrounds the heart, it fills with fluid, with blood, whatever, and it restricts the movement of the heart. And if our heart's not beating well, then, well, we're kind of dead or heading that direction. And so then in the bottom picture with the tension pneumo, so what happens is if you have like a puncture or something, you see there on the very bottom left, and on inspiration, all that air goes in. But what happens is when you exhale, that air gets trapped and builds up that pressure in there. It can't get back out where it came in. So it's going to deviate the trachea and everything over to the good side, if you will. Okay. So does everybody see how there's like a little hole there with a little flap? When you inhale, the air can come in, but then that little flap or whatever kind of closes. And when you try to exhale, that air can't get back out. And so it makes a bad situation worse. Okay.
So is it basically like air is just being trapped in one side of your chest?
Yeah. And it's pushing on everything, putting pressure on everything, and it's deviating off to the side.
Okay.
Yep.
Thank you.
Yep. It can't get back out. Okay, so asystole. Your patient's dead. Not a good thing. Dead's not really therapeutic. So again, CPR, start with the compressions. Let's get some oxygen going. Epinephrine, 1 milligram every 3 to 5 minutes. Okay, identify the causes. Start thinking about H's and T's. The doctor's going to make the determination about when to terminate the code. It's going to take into consideration a lot of things. Are they a DNR? Do they have comorbidities? How long have they been down? How long have we been working on them? Does anybody know, like, God forbid, they collapsed in the park and nobody started CPR and it took 13 minutes for medic to get there. And then they started working on them, loaded them up, and got onto the ED in Charlotte traffic another 10 to 12 minutes. You know, so you got to take all those things into consideration. Now, if it's in a controlled setting like the hospital, still, how long have they been down? When was, you know, if they're not on a tele floor, if they don't have a monitor on, when was the last time somebody rounded and saw this person, knew they had a pulse, knew they weren't apneic, knew they weren't unresponsive? How long have they been down? Okay. And then the effectiveness of our resuscitation. Are we seeing anything happen with the epinephrine? Are we seeing anything at all when we analyze? Have we even been able to pick up any kind of rhythm, dysrhythmia on the defibrillator or the monitor that's saying, hey, go ahead and deliver a shock? You've got to get something started in those ventricles in order to be able to shock it. So, you know, that's what the epi comes into play for, because the epi is going to work on that excitability of those ventricles and try to get something started, try to get some electrical activity started, and then hopefully we can deliver some electrical shock and get them resuscitated. So all these things are going to come into consideration. Okay. Okay, pulseless electrical activity. We talked about this a tiny bit when we were doing our EKG class, is that you might see a little bit of a, let me see if I have a slide on that. I think I do. Yeah, I do. Next slide. So let me just move on to that actually. So you might see a little bit of movement and you think, oh, maybe it's just, you know, bradycardia or something else is going there, but really you're checking your patient and there is no electrical activity happening at all. So you're starting to think about, you know, your H's and T's, what could be going on with them. With that, you're looking at your QRS. Is it narrow? Is it wide? With a narrow QRS, you're thinking kind of like a mechanical problem, maybe like cardiac tamponade, attention pneumo, a PE. If you have that widened, you might be thinking a metabolic problem like hyperkalemia. Are they having toxicity from like a sodium channel blocker or something like that? So a narrow QRS might mean that there's a mechanical problem, and the wider QRS might mean that it's a metabolic problem. So thinking about those H's and T's. Okay. All right. But with this, you know, you're giving them the epi. You might have an order to give them some atropine. So just be aware of all that. Okay, symptomatic bradycardia. We really didn't get into a whole lot. We talked about the basics of bradycardia in EKG class, but when we're talking about symptomatic bradycardia, we're thinking about the heart rate definitely below 50. Systemic symptoms, so altered mental status. Why would that be?
Not enough perfusion to the brain.
Absolutely, absolutely. So altered mental status. We might be thinking about chest pain. We might be thinking that they're hypotensive, right? So those are some things that you might see in your patient, and that would make them symptomatic, bradycardic and symptomatic, okay? Medications there on your screen that you should be aware of for somebody with symptomatic bradycardia. Okay, and then looking at your other issues or concerns during a code situation, family, other people around in the hospital, staff, and also the do not resuscitate orders. So what is your experience? Have you guys been in a code situation and have you left the family at the bedside? Yeah, Jonathan saying yes, Lauren saying yes. Anybody else been in a code situation where maybe they have not allowed the family to stay at the bedside?
Yeah.
Yeah.
I am.
Okay.
I mean,
So-
for me, I work for medics, so we're just going into the house, so they're there.
They're there. Yeah, you can't really kick them out of their own place, can you? Yeah, yeah. Well, it used to be that we just like made them leave, you know, they couldn't be here. We need to have our space and do our work, and we don't want them to see what's happening. But really, it has been found, through lots of feedback and lots of study, that if we leave the family at the bedside, they can really see the effort that we have put into saving their loved one. They know that we really tried, and it helps them with that closure process if the patient isn't able to be resuscitated and survive. So more and more, you're seeing that the family is being left at the bedside. Now, obviously, they can't be right up there holding their hand at the bed rail, but if they can be somewhere in the room, and usually there's somebody that's kind of sitting or standing over there in that area with them, kind of just telling them what's going on, making sure, because we don't need two patients in this situation. We don't need them collapsing on us and that sort of thing. So that's something we're doing. As I mentioned early on, the room gets very full very quick, and you're kind of spilling out into the hallway with your timekeepers and things like that. So the door typically is not closed. We try to draw the curtain to keep privacy from other nosy Nellies, I guess. Other patients that are walking the hall, other family members that are just like, oh, what's going on? There's people like, I call siren chasers. Like get all excited. They love the adrenaline rush. And so people are just nosy. They're just nosy, but they don't need to know. So make sure you're keeping that patient, make sure you maintain their dignity. Keep that curtain drawn, keep them covered as best you can. Nobody needs to know what's going on in there just for the sake of gossip or guess what I saw. That's completely inappropriate, even for our other patients and visitors to be able to see that. Same way with staff. Just like you guys have been taught from day one, you don't get into someone's chart unless you need to know. Same thing. If you are not part of that code team, if they have not asked for your assistance, don't go just for the sake of just being there, just to observe. Unless you're, of course, in an orientation process, and they're probably going to bring you in and make you watch and see what's happening. But we don't need to be in the way. We're trying to save someone's life. And so need to know basis, for that situation. Also, with the concerns for staffing, it's really important that you do a debrief with the code team after the code has taken place, okay? It might be your first code experience, and you need to kind of mentally, emotionally work through what just happened. The patient may have not survived. It might be the first time you experience death. So debriefing with the staff is really important. It's also important because it teaches us, it helps us to learn what could we have done differently? What could we have done better so that our next code situation, maybe we can have a different outcome or we can get something accomplished quicker. So debriefing can, work on multiple facets there. And then the DNR orders, make sure you honor those. We ask for those types of things upon admission. We need copies of those. Sometime during the length of a hospital stay, somebody will consent to signing a DNR, that they don't want any kind of resuscitatory efforts if they know that they're in a terminal disease or something like that, or if they're old and they're tired and they're just like, you know what, I don't want somebody pounding on my chest. I don't want somebody sticking a tube down my throat. That's no quality of life for me. I don't want that anymore. But if you have them, make sure they're honored. Now, this gets a little sticky. That sounds simple, but it gets a little sticky when grandpa has 4 grown children and they all want something different that's going to satisfy their soul. And they forget about what's going to satisfy our father and his wishes. And so you get into all this family drama and chaos. And these 3 say, no, we're going to honor daddy's wishes. And this one says, no, you absolutely are not. I am a nurse, or I am a doctor, and I know what they're doing, and they can save him, and this is blah, blah, blah. And you get into all this drama. It will wear you down. It will wear you down. So the DNR is what you need to follow. There's no negotiating. That patient, they signed their wishes. If they had a healthcare power of attorney, that healthcare power of attorney might be the one that made that decision. But if the DNR is written by that doctor and it is in place, you need to honor that. Okay?
Ms. Teben?
Yes.
So that a DNR is usually like very clearly posted by that patient's bed, correct? Because you don't really want to get in a situation where you're starting on that.
So we don't really post anything. It's in the form of a bracelet now. just kind of like patients will have a bracelet that says I'm a fall risk, or no blood draws or blood pressures in this arm, or no blood products. It will be in the form of a bracelet. But in Atrium, you know, across that top bar that has like your patient's admission date, their doctor, their name, their date of
Right,
birth, their
yeah.
allergies, it's also up in that area too. It'll say no, it'll say DNR if they have one, but it'll be in the form of a bracelet. It's not something that we post in the room.
Okay, so and if they have that and you go in their room and they're pulseless, would you still call a code just to get people in there? How would you handle that?
Yeah, so no, not necessarily. Unless you're not, let's say God forbid somebody forgot to put the bracelet on the patient, you know, and that happens. We're human. We really try hard to make sure we have everything in place. But let's say that it was a relatively new order and somebody didn't get the bracelet put on the patient yet, or somebody didn't get it updated in the computer yet, and maybe they had just signed the paperwork. You would call your code, and you know, you might start your resuscitative efforts, and then somebody says, oh, they just signed the DNR, or this patient's a DNR, it didn't get a bracelet on them, whatever. And so then you're going to stop and honor that. But you might start that resuscitative effort if it's not properly identified initially. Yeah.
Okay, thank you.
Yeah, you're welcome. You're welcome. Okay, and then finally, documentation. I mentioned there might be 1 or 2 record keepers. There's a lot going on during the code. One person might just be doing all the IV fluids and meds, and somebody else might be documenting like when the code started, how many cycles of CPR were on, how many times we've analyzed and delivered a shock, when they were intubated, that sort of thing. So when phlebotomy came and drew the labs, you know, so you might have more than 1 record keeper. But the really important thing is that everything gets, you're doing it a lot of times on paper if you can't get into the computer right away. And you just need to make sure all that gets scanned in so that it is in the patient's chart then, because of this patient, if we are able to resuscitate them and get them to the ICU, then, you know, that information is going to be really important and helpful in knowing like what did they go through, what all happened. And so that all needs to get scanned into the chart. Now, that doesn't take the place of giving a bedside report. If your patient is able to be resuscitated, you're going to move them to the ICU. A lot of times the ED, when somebody comes in, let's just say somebody came in and they're sick, they've been thrown and going for 5 days, and we need to get them, they're hypovolemic, we need to get them fluids. The ED nurse will just call the medical floor and say, hey, this is your patient that's coming to you, blah, 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 blah. Well, in a code situation, we're not doing that over the phone kind of handoff, if you will. Same thing as somebody come back from recovery room after surgery to the floor, we'd probably just give them a verbal over the phone. This is what went on with the patient during recovery. In a code situation, you're going to go with that patient and with the team to physically transport that patient to the ICU, and you're going to give a bedside report. There's a lot of information that needs to be relayed, and we're not going to count on that ICU nurse to have time to be able to read everything you know, right then, right now. No, she needs to get that patient settled. She needs to get an assessment going. And so giving a thorough bedside report, and then as he or she has time, you know, they'll be able to go back into reference that documentation from the code situation. But you definitely go with your patient. You see them off and give that bedside report. So. Okay, I know that's a few minutes early, not too much early, but we had some great questions and great conversation here. But does anybody have any questions before I let you cut loose a few minutes early for lunch?
I have a quick question. Bridget, I really should know this, but do you defibrillate a pregnant woman?
Yes, you can. You can.
Okay.
Yeah, you can. And did Janie talk to you guys about any resuscitatory efforts or ventilation or anything with a pregnant woman last week?
No.
Yeah. So I mean, we're still going to try and save the mother, because if we can save the mother, we can save the baby. But I have been in a code situation in the ED years ago in an atrium facility where the mom came in and there was no idea. Somebody had just found her. And somebody was able to at least tell us that she had been experiencing some preeclampsia, so high blood pressures. somebody was able to at least give us that information. But there was no knowing how long she had been down, and so right then we just cut her open from stem to stern in the emergency department and got the baby out. And the baby didn't make it either, but they immediately started the resuscitation efforts on the baby because it really was, what do you do? But we do try to save the mom because we get the mom's circulation, but oftentimes it's a little bit dependent upon was it witnessed? Do we know anything more? How long have they been down? That sort of thing. But very sad. It will change your life. You guys are going to experience so many things that are going to change you. And you're going to experience feelings that you didn't know you had. So it's a very rewarding career, but we also experience a lot of mental anguish. And so learning how to cope with that, again, a huge part of the debriefing, because the first time you lose somebody, it's going to change you. It's going to really change you. I don't want it to make you doubt that you chose the right profession. I want you to find the means and the mechanisms and the avenues to find the find the support that you need and how to work through it on your own emotional and mental pathway. So we go to CPR class and we think, okay, we're just doing this, but when you do it for real, it's going to change you. I can't really say anything else. So, okay.
I have a quick question.
Oh yeah, go ahead, Abby.
Oh, sorry. I remember we were talking about the right subclavian for like the different spots for IVs and everything.
Yeah.
Said that only like doctors or people that get can place that. I don't know what.
Yeah. So as a nurse, you're not going to place that. So it's going to be a physician that places that. Yeah. Right subclavian. Yeah. But if you start some peripheral IVs, you want to throw in something big like an 18 gauge.
Okay.
Yeah. Yeah.
So could you be that or like in the AC, like in the arm or?
Yeah. I mean, again, it might be, the AC is it's a bigger vessel. It's going to be a bigger access point for you. We tend to not like ACs because when people start to bend their elbows, it kind of occludes everything. But in a code situation, get it. That's fine. We can move it to their hand later. But the little tiny vessels in your hand, for the amount of fluid and medications and things that we need to dump into somebody, if I had to choose between my hand or my AC, I'd probably go with my AC. If I had to choose between my AC and the right subclavian, no question, I'm going with the right subclavian. If I had to choose between a little tiny vein in my hand and an IO, I'm going to go with the IO.
Right.
Yeah. So you just got to kind of think that through. But like labor delivery, OR patients, we don't like to throw things in their AC because even patients on the medical floor, because what do? When we use our arms, we occlude that, and then the machine's beeping, the patient's like, can you shut this thing up? That kind of stuff. But if that's what we need to do initially, that's fine. Do it. We'll move it to a little hand or something if we get them resuscitated and they hang out with us for a couple of weeks and or whatever. But yeah.
Okay, thanks.
So just think through about the delivery and how we're getting this into circulation and what is my best route and what's going to be the quickest and allow me to do everything I need to do. So
I don't know if this is a dumb question, but does every patient who codes go right to the ICU?
If they survive, yes.
Okay.
I have not experienced anything in my career. I haven't been nursing as long as Jane and Janie, but I've been nursing a long time, and I've not seen anybody in my career not go to the ICU because they're going to need to be on a telemonitor. Even if we don't have to intubate them right away, until we find out what the underlying cause was, the likelihood of it happening again is pretty significant. And we got to figure out, looking at those H's and T's, what's my underlying cause? Excuse me. And so we can more closely monitor them, right, in the ICU, because you might have 1 or 2 patients. How many patients do you have on the med-surg floor? Maybe 5, maybe 6. Not going to be real easy for you to monitor them. So, yeah. Good questions. You guys have had great conversation. I appreciate everybody's interaction today and participation. You guys you guys are well on your way with this material. So either you work in an area or you've read ahead or something, but you guys have done really, really well today. So just continue to review it. We're going to start with neuro this afternoon, neuro assessment with Dr. Benetti this afternoon. I opened the spinal cord injury video that is on the Moodle page. That's one of your online lectures. We've had that online for years. It's not something new because of COVID. So you guys should be able to watch that at your leisure here over the next couple of days and start, you know, getting into the other neuro videos too that Jane and Janie have posted as well. I don't think those are open yet, but I imagine they'll open them, you know, here after they get some of these neuro live lectures started. So, okay, well, you guys enjoy your lunch. Thanks again for your participation, and we'll see you this afternoon.
Thank you.
Bye-bye.